don't get audio is the only problem. Plug in. We should have all volume though. There we go.
I'll go see if she can.
Hello? 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 Well, we're getting green, so we should have volume now. Byron's checking again. Yeah. He's actually running into connection point. There we go.
Yeah. Okay. Let me go.
Peter?
Yes, what would you have?
Yeah, just read. Okay, we got it. Yeah, there's nobody in there. She got it.
Good morning, everybody. Thank you for being here and thank you for your patience. We were having a little technical difficulty. You are streaming live on YouTube, so smile pretty into the camera. Again, thank you for being here. My name is Ellen Jones. I'm the Educational Programs Manager here at Braille Institute. And if you are new to Braille Institute, I have put on each chair a catalog. This is for this term. It describes all of our free classes and services. So if you want to take that home, this comes out 3 times a year, and since you have given us your name and address, you will be getting copies of this. And it also has registration forms to fill out for classes. It has all of our seminar information, so it's a real handy tool to have. I've also put on your chairs a flyer about Connection Point, which is our new technology center, which is just outside those double doors and to your left. And Francine and Margaret are in there this morning, and they can make an appointment for you if you would like to have a demonstration of all of the equipment that's in there. But you feel free to walk in there this morning and take a look at it. We're very proud of it. We just had the grand opening, and it was provided solely by donations. Braille Institute is a privately funded organization, and so everything is free, and the Connection Point and all of the seminars are thanks to all of our donors. So I know some of you are here today, so thank you for donating for Connection Point and for our seminars as well. I also put on your chair a green flyer, and this is our next seminar, and it's on apps, and people are asking me what is an app. An app is an application that's on your iPhone or your iPad, and it helps you with, if you're visually impaired, for example, it has readers for like the barcodes in the grocery stores, what color your clothes are, what denomination of money and whatnot you have in your hands. So that's on the 15th, so if you'd like to sign up for that, you can do that at the front desk. I also have a seminar evaluation on your chair, so if you could please fill that out and either leave it on your chair or put it on the table as you leave. We are always interested in not only what you think about this seminar, but which seminars you have interest in the future. So please take a few moments to fill that out at the end of the seminar as well. I would greatly appreciate that. And now it's my pleasure to introduce Dr. Jeff Huang. He and his wife have a practice in La Quinta, and I'll let him tell you a little bit about his background so that I don't get it incorrect. But it's a pleasure to have him here today to talk about macular. He also has some cards over on the registration table if you'd like to pick one of those up after the seminar as well. So without further ado, here is Dr. Jeff Huang.
Well, thank you, Ellen, and thank you to the Braille Institute for inviting me to do this. This has been a huge pleasure, and all of you for attending this morning. I am Jeff Huang. I lived in California for most of my life, but I went to school for optometry in UC Berkeley, and since then has done a residency out in Miami, Florida at the Diagnostic Eye Institute, and I served at the VA for a couple of years before moving back here to California in 2008, and I've practiced here in the Coachella Valley since about 2008, or the end of 2008, and plan to stay. As she said, my wife and I have a practice in La Quinta. Macular degeneration is one of those huge, big interest for a lot of people, and most of it is because of its damage it does to our eyes. And also, until very recently, there hasn't been very good treatments for macular degeneration. So, for those that have it, not more than 10 years ago, there was very little we could have done for you, besides allowing the disease to progress on its own and depend on treatments that really were not proven to work very well. More recently, and part of the reason why you've probably heard from other doctors, retinal specialty especially, more recently we have now treatments that work very well. And for people who have the very severe kinds of macular degeneration, there is now an opportunity to really reduce the amount of vision that is lost, and in some cases even improve it beyond when the first onset of the disease, what happened at the first onset of the disease. So for those reasons, it's important to talk about it, because looking to the future, it is becoming more important to diagnose the disease early, to attack the early forms of the disease, and then to aggressively monitor so that if there is any sign of progression to the wet kind, the kind that causes vision loss very quickly, that we get you to the right people to get that treated, and that way there is some confidence that we can minimize the vision that is lost and minimize the interference in our lives. And vision is one of those things that we all take for granted when we have good vision. But I don't think anyone, for those who have normal vision, they can't imagine how it is to not have normal vision. So that's why I'm here, and that's why the Braille Institute asked me to come here, and let's go on. So, I'm going to kind of give you a broad view of macular degeneration. And the reason is I wanted there to be a little bit of an understanding of what the disease is, and where the research has been to look at the disease and try to solve the problem that it poses. So to do that, we're going to look a little bit at the anatomy of the eyes, the physiology of the eyes. We're going to separate the disease into the dry and wet kind. And for those who have macular degeneration, you are very familiar with those two broad categorizations of macular degeneration. And then to look at the progression of the disease, what we can do to modify it, or to slow it down perhaps, or to somehow reduce the rate of progression or conversion to the wet kind. And lastly, the new treatment options that are available. So that's sort of the broad topics for today. So why do we care about macular degeneration? We talked about that a little earlier. Part of the reason is it is the leading cause of vision loss and blindness for those who are over the age of 50. Healthcare issues have been in the news a lot in the last year or so, and this disease has contributed at least a little bit to the rising cost of healthcare, because of the treatments that are available tends to be very expensive. The drugs that are used are new drugs, and their treatments are very effective. On the other hand, it is an expensive treatment. For those who have it, it significantly reduces the quality of life. So, if you are still working, you may not be able to work. So not only is it a burden on your own society, on the healthcare costs in general, but on your own financial well-being, and also just the independence. Those who have severe macular degeneration, they may not be able to drive, and it interferes with what we have, what we've taken for granted really all throughout life, and not being able to do the things that we've come to enjoy. And the last thing is, more importantly, there are good treatments available, and it's important to talk about it because it's important to get this diagnosed and treated. So this is kind of a sense of how macular degeneration may appear. And it definitely doesn't appear that way to everyone, but it reduces your vision in the very central part of your visual field. And we direct our eyes when we go to the eye doctor and we ask you to look at the eye chart and you read the letters. You direct your eyes to look at each letter so that it falls on the macula. So the macula really is the very central part of our vision. Without it, we don't have any of the clear, high-quality images that we see. And it's right in the center because that's where our attention is. And in this case, I think what the pictures are trying to depict is the areas where we would normally direct our attention are blurred or blacked out because of the presence of degeneration in that part of the eye. We'll go into the anatomy a little bit in a second to see why that is. But I was speaking with the staff just before we started, and they commented on how prevalent macular degeneration is. And in looking at this chart, it is very prevalent, especially as we get a little older. So overall, for those who are in the 60 or the 6th and 7th decade, somewhere between 30 to 35% have some early signs of macular degeneration, and somewhere around 10% or so have the late stages of macular degeneration. And that is a large number of people. Similar line graph that shows about the same thing. And the main point here is as the population gets older, as we get a little older, the risk and the prevalence of macular degeneration definitely increases significantly, up to well over around 50% for early signs of macular degeneration. So to start, let's talk a little bit about the eyes, its anatomy, how it functions, and then we'll go into why macular degeneration is such a problem. So first of all, a brief description about the eye. The eye is a ball. It's not empty on the inside, but there's a space in the inside that's filled with fluid. The important things to look at, you're looking at the picture to your right. You're looking, of course, from the front part of the eye. The retina is the pink tissue you see on the background there. I have two lines drawn pointing to the macula corresponding to those two pictures. And as you can see, the macula is a very small part of the eye. And on the picture on your left, there is the label fovea towards the bottom at the end of the red arrow. That little divot, that little dented space is where we have our best vision. That's where we see 20/20, that's where we get most of our color vision. And compared to the rest of the volume of the eyes and the surface area for vision, it only occupies about 2% of that entire space. So we're talking about a very small part of the eye that is responsible for the majority of what we view and how we see the world. So this is a color photograph of just the very back of the eye. Basically, the optic nerve, which is the nerve that you see that little yellow structure, and the area right around the macula. So that's what this photograph is, and that's actually my right eye. And I can show you that it's a healthy eye. And a couple of little features. The optic nerve, of course, is important. There are blood vessels that we can see emerging from the optic nerve, feeding the eye, and also veins that course through and feed back into the optic nerve and drain out of the eye. The macula only occupies about 2% of the entire surface area of the eye, and that's where we get 20/20. So you'll notice that the macula has a slightly darker pigment than the surrounding area, and there are a couple of reasons why, and that's also an area of active research to see if we can replenish that pigment and perhaps reduce the progression of macular degeneration. So the pigments that are in the macula are actually important component. The macula is where we get most of our color vision, because that's where a subset of our receptors that are activated by light are most dense. Now, before we go on, there's an analogy to the eye and why the anatomy is the way it is. If you kind of think about the eye, the front part of the eye as a camera, and its function is to focus, help focus the image. The quality of the image is determined by the retina, and that is more like the pixels on your HD TV. The higher the pixel, the higher the density of the pixels, the better quality of vision you'll have. And in the macula is where the highest density of receptors, light receptors are, and that's the reason why we have our best vision there. So we'll continue with a little picture, a diagram of what I just spoke about. This is a blown-up diagram of the fovea. The receptors, what we call them photoreceptors, they're the receptors that are activated by light. Every time we see light coming through the eyes, these receptors are activated, and then they send a signal down the pathway towards the brain. There are two main types. It's not important to remember what they are, but the cones, the second one, is most responsible for color vision and high quality vision, and they are most populated or most densely populated within the macula. In fact, the macula is almost exclusively cones. These receptors have another type of cell that functions to regenerate their function. We call those the RPE cells. And part of its function is once the receptors are activated, they become kind of non-functional. And to then function again, these RPE cells helps them. And the reason I mention this is all this comes back later to why, to the spectrum of macular degeneration and where the damage is done. And lastly, there are two blood supplies to the retina. One lies on the inner surface, and one lies on the outside. The inner surface being, this is the inner surface of the retina. That's the outer surface. And there are two blood supplies, one on the inside, which is not at all involved in macular degeneration, but those that are on the outside, out here, are very intimately involved in macular degeneration. So keep that in mind, because after all, when the wet kind of macular degeneration occurs, it is those blood vessels on the outside that cause most of the damage. Another diagram of the anatomy of the eye, going over basically the same things. These are the blood vessels that I spoke of. Okay, this is a basement membrane and the RPE cells that I talked about earlier. This gives you a perspective of how what the thickness of these things are compared to each other. And the photoreceptor cells are right here. So the very tip of the photoreceptors inserts into this layer. The blood vessels, the blood inside these blood vessels are not allowed into the retinal tissue because the basement membrane prevents it from doing that. And in macular degeneration, you have essentially an aging process that causes a thickening in this tissue so that it becomes less effective at delivering blood, or not blood, but nutrients from these blood vessels into the photoreceptors. And over time, that degeneration gets worse, and this layer becomes more fragile and brittle, and when that breaks, the blood vessels from here starts to grow into the retina, and that's where all the bleeding and leaking of fluids occur. So that's sort of, in a very brief nutshell, what macular degeneration is and how it causes this damage. So a little bit more about the function of the RPE and how it's related to the photoreceptor cells. Every time these light receptors gets activated, it loses part of its function. And to regain that function, it has to, that chemical process occurs in the RPE cells. And a lot of that is dependent on vitamin A. And for those who have vitamin A deficiency, one of the first things that happen is they lose their night vision. That's because without vitamin A, the eye is no longer able to regenerate those light receptors. And so we lose even the most sensitive part of our vision, it's the night vision. So that we're no longer able to, those cells are no longer able to be activated by low light levels. Oh, and one more thing. The way this diagram looks, it's very important that the retina, the architecture of the retina stays the way it is. If there's any interruption, if there's swelling somewhere in here, that alone could cause vision to be compromised. So not only is it important, and you can kind of see the two diagrams, you have some very nice vertically oriented cells here, where here the cells are starting to be a bit more spaced out. The architecture, the orientation of the architecture is changed. And that is also very important in the functions of the retina, how we see. I think we're almost done with these slides on anatomy, but one last point I'll make is part of the reason why macular degeneration happens at the macula is because to have that very good vision, a lot of metabolic process occurs there. It takes up a lot of energy for us to process, so that the large blood vessels that are there, not only do they supply nutrients, they also take away some of the heat that is produced by the active chemical reactions. And with this metabolism, the cells are really taking away a lot of the waste material that occurs within the light receptors and within the RPE cells itself. So all those processes create a situation where you have an accumulation of waste products from metabolism that in these cells that do not divide, we don't get more RPE cells over a lifetime. For these cells that don't divide, these waste products have no way of getting out of these cells. So they tend to accumulate. And for some people, that accumulation is not handled very effectively. And that is basically it lays the foundation for the beginnings of macular degeneration. So that gives us an idea of how macular degeneration gets started. Going back to the pigments for a second, we know that macular degeneration affects white folks a lot more than black people. And those who are pigmented, Asians and Latinos are somewhere in between. And part of the reason may be that we just have more pigment than white people. And going back to that photograph, remember there's a large accumulation of pigment in the macula, and having some more pigment may be protective. And the new vitamin studies that we'll go into later are looking into whether or not taking supplements to increase the pigments in our bodies may be helpful to slow down macular degeneration. Kind of went over this a little bit. One thing that I will point out here, with aging, one of the first things that I'll see or your eye doctors will see when you go in and they tell you have the beginnings of macular degeneration is that they'll see the accumulations of these things, what we call drusen. They're basically thickening and accumulation of a byproduct of metabolism that's in this layer right there. So the layer that separates the blood vessels from the light receptors. And they appear yellowish. I have some pictures for you later, but they appear yellowish. And when we see these, that's the first indication that there is some early changes happening, and then we tell you you have dry macular degeneration. So for the most part, when we are talking about dry macular degeneration, we know when we see the presence of these drusenoid bodies. Okay. So going on, let's talk about what are the risk factors. How can one reduce one's risk of having macular degeneration? And there are several things. The first thing is aging, and unfortunately there isn't a whole lot we can do about that. But the second thing that I think is very important is smoking. And I think fortunately for this country, the number of smokers has declined over the last couple of decades. But smoking, along with all the other health risks, are known to cause accelerated aging and processes that accelerate aging. So macular degeneration, having been a disease that's very related to aging, tends to be more aggressive in those who are long-time smokers. So if you know anybody who are smokers, it's another reason to quit. Sun exposure is a little bit controversial, but I personally recommend everyone to have sunglasses. We know that light exposure can cause other problems, but in the eye, there's been some thought that blue light, especially, may be associated with macular degeneration. So the simple fix for that is just always have your sunglasses with you. Dieting or diet habits may be an important factor as well. A lot of the new vitamin studies are looking into micronutrients and trace minerals that our body needs for its normal function. A lot of which should be in our normal diets. Unfortunately, it is not, because we have a culture where we eat a lot of meat and high fatty foods, and one that we don't always emphasize on vegetables, fruits, things that are high in vitamins, micronutrients, and whether we take in a lot of processed food. And that may be part of the reason why macular degeneration is as big a problem as it is today. But then again, people are living longer, so there's no way of really knowing what the balance of factors are. But that is an area where we're looking to see whether a change in diet habits, or at least an increase in some of those micronutrients, may be very helpful. Aspirin is not related to the cause of macular degeneration, but aspirin, as you know, is a blood thinner, and if you have the wet kind of macular degeneration, it could cause the bleeding to be a little bit more aggressive. Cataract surgery. It's not the inducer of macular degeneration, but it could make the wet macular degeneration more aggressive, or if you have a severe dry macular degeneration, it could cause you to convert to the wet kind, partly because of the inflammation that is involved after cataract surgery. So if you're about to have cataract surgery, and it's a great surgery, it's done very successfully in this country, but if you're about to have cataract surgery and you're known to have macular degeneration, your doctors should be following you a little bit more closely in the immediate post-surgical time. And lastly, just like the first part, heredity has a big influence. Overall, we know that in the world population, those of North European descent have a much higher risk of macular degeneration than those of African descent. So where your parents come from, where your grandparents come from, that has a great effect on what kind of diseases you are at risk for. There's nothing we can do about this part, except I think at some point in the future we may be able to study one's risk disease profile and maybe be able to attack some of these diseases a little earlier on. But at the moment, there's nothing we can do about our genetics. Some diagnostic tools. If you've been to an eye doctor and you have macular degeneration, some of these things have already been done on use. But I want to just talk briefly about how we make the diagnosis and how we follow the progression of macular degeneration. The first thing we do, of course, is to look at your eyes thoroughly. Make sure that we can measure your vision. We look at how the retina looks. And then we follow that with a photograph, a picture of the eyes. No matter how well most eye doctors are not good artists. They can't draw your eyes. And so a photograph is the best representation. More recently, since maybe about 2003, 2004, we have a new instrument called the OCT. It's essentially almost a live scan of the retinal tissue. And I'll show you some pictures later. It gives you almost a detailed anatomy, just like some of the anatomy pictures I showed you, of what's going on inside the eyes. And lastly, a more invasive procedure called fluorescein angiography may be done to find out where the leaking is coming from. Now this last tool that we used was more common in the past. But since we have now these new injectable drugs into the eye that treats macular degeneration, the FAAO or fluorescein angiogram has not been as useful or hasn't been used as much as it's been before. Mainly because we don't have to really need to know where the bleeding is coming from. When we inject the drug, it goes everywhere in the eye. So the presence or where exactly is the location of bleeding is no longer as valuable information. So photography, that's the first thing we do. That's my eye again. And I'll show you some more photos of eyes that have macular degeneration later. This is just an introduction to these different diagnostic tools. This here is the OCT, not the picture on top, but the picture on the bottom. And if you compare the two pictures, the picture on top is a diagram in a textbook. Picture on the bottom is an actual scan of somebody's eye, and we are able to see down to a very minute detail of all the structures of the eye. And here are the blood vessel layers that we talked about earlier. This is the fovea, the dip where our best vision is. And most of the retinal layers are here. And this other layer where it's also lit up is where the photoreceptors or light receptors are. So the retina now can be scanned in such a way that we can look directly at where the problem is, whether or not there's even a little bit of swelling in the retina, and very easily tell you if macular degeneration is present and whether there's bleeding or swelling from the conversion to the wet kind of the disease. And lastly, this is a fluorescein angiogram. The way it works is we inject a dye into your artery. That dye is going to travel throughout the body and also into the eye. And we know when it's going to hit the eye. It takes a couple of seconds. But when it does, we start taking photographs. So it's a time-lapse photography of the eyes. And the way the dye, or the way the blood travels, it will first go to the background first. So it will start to light up in the background. You can see that the blood vessels are still empty. There's no dye in the blood vessels yet. The dye will then enter the arteries of the eyes first, and then it will reverse, or not reverse course, it will then backflow into the veins and drain out the eye. So in that way, we can follow how blood travels through the eye by following how this dye is traveling through the eye. If there's any leakage, inside the retina, we will see it lights up. Here you see some bleeding. This is the diabetic eye and not macular degeneration eye. But these little bright spots are where the blood vessels are bleeding. So that's a fluorescein angiogram, more invasive because it involves an injection, but fortunately not as necessary now to make the diagnosis and treatment of the disease as we used to. So now we get to the stages of macular degeneration. We're going to talk basically about the two broad categories, the dry kind, and I'm going to go through some pictures of dry macular degeneration and then what we're doing about it. A few years ago, there was a large vitamin study that was conducted with the National Institute of Health and the National Eye Institute that looked at whether or not vitamins are helpful. And due later on this year is the second of that study, which looked at some other vitamins and see if those other vitamins may be even more important supplement to the eyes. So we're going to go into all that in the staging of macular degeneration. when we look at the eye, earlier I showed you a histology slide of drusen. This is how it looks inside the eye. And when we look inside, we see these little yellow spots. It may be hard to see because they are subtle. And in this case, this is a very early case of macular degeneration. That's what gives us the hint. These little yellow spots we call drusen. The hint that macular degeneration is present. At this stage, there is no way that this person would have known that he or she has macular degeneration because there's no visual impact at all. This person very likely has perfect 20/20 vision. So at this stage, there's very little that needs to be done except to present the starting of macular degeneration. It may stay here for a very long time, and you could have this be at this stage for a very long time and not be at all be affected by the visual impacts of macular degeneration. But this gives us a hint that the aging process is starting to show up inside the eyes. Now you'll notice that a lot of these drusenoid changes occur not within the macula, but outside of it. Of course, those that, if we do see drusen in the macula, that causes an additional risk to progression of the disease. This is a picture of somebody who has a very large number of drusen. And you'll see that a large number of them in this case are actually within the macula. So now in this case, this patient, this person, may start to notice that the vision is not as good as it used to be. They may come in and tell me they need to change their glasses. They tell me that every time. But that's not necessarily the case. They may have gone from good 20/20 vision to now maybe 20/25 to 20/30. And that's the reason why is there's the start of some thickening in the macula that's causing some disruption to the architecture of the eye. So even though there's no bleeding, the architecture of those light receptors like you saw earlier that was perfectly vertical, that architecture is starting to be disrupted, and that's the reason why their vision is not as good as it used to be. So, basically, the presence of these drusen tells us that there is an aggregate aging change to the eyes, and that we can expect this change to continue. And with time, and it's different for everybody, the rate of acceleration or progression is different for everybody, but we know that the normal metabolism that occurs in the eye is starting to be disrupted, and with time we can expect more progression towards at least more drusen, or over time going on to bleeding and swelling. So here, earlier we saw a picture where there's only a few drusen. Here is what happens when you get a lot more of them. They don't appear as little yellow dots anymore. They start to coalesce so that you get just an area where it's yellow, where we know that the retina is not as healthy as it used to be. And I generally categorize that as a moderate macular degeneration. At this stage, there is some visual impact. The vision is not as good as it used to be. It's maybe about 20/60 or so. And things will appear a bit faded out. Although there's no significant, or there's no immediate danger, or no sudden change in vision is what I'm trying to say. At this stage, there's no sudden change in vision. You may sort of arrive here over a number of years and notice that the vision has gradually declined. Until what we get in severe macular degeneration, there's a little bit of confusion that we focus so much on the wet kind of macular degeneration that sometimes we neglect the dry kind, because people can lose significant vision from even the dry kind of macular degeneration. When those drusens get thick enough, when the RPE and its underlying basement membrane gets so thick, the RPE starts to die off. And so even without the presence of blood or swelling, the loss of RPE will then cause the light receptors to be lost as well. And then if there are no light receptors, there's no reaction to light. And so even in dry macular degeneration, it'll take a long time, but people can become legally blind even from the dry kind of macular degeneration. So what can we do about that? We talked earlier about the availability of vitamins, and we'll go into those vitamins, and then how taking these vitamins can reduce the risk of progression a little bit. Okay? And we're talking about a reduction over 5 years of 25% conversion to the wet kind or to the severe kind of dry macular degeneration. Does that mean if you start taking these vitamins, you won't get wet macular degeneration in 5 years? No. You could be one of the other 75% that converted. Does it mean that it will allow you to not lose vision as you had it before? There's no way of measuring that. But we know overall, of the thousands of people that were involved in this study, about 25% of them that may have converted did not convert by taking these supplements. So it's an important tool, but it's certainly not one to be looked at and say, well, this is a cure for macular degeneration, because it is not. And we're looking to see if other supplements may be more effective. In this original study, there were basically 5 ingredients: a high dose of vitamin C, a high dose of vitamin E, high dose of vitamin A, and then 2 trace elements, zinc and copper. We'll go into what the effects of these vitamins are, but some of these are not cleared very well out of the body. So if you do need to talk to your primary care doctor to see if these vitamins are good for you, because some of these vitamins can be toxic if they are used in too high a dose. We'll talk about each of these specific vitamins. Vitamin C is very common. It's probably the safest of all the other vitamins out there. It's a water-soluble vitamin. We get it from fruits and vegetables, of course. And if we all had a better diet, we all had our recommended serving of fruit and vegetables, none of us would be lacking in this vitamin. In other animals, most other animals actually are able to produce vitamin C on their own. We don't. We have to get it from our diet. And you can't overdose on vitamin C. That's the nice thing about it. Its function is to maintain the connective tissues in our body, the collagen in our joints. It involves plenty of vitamin C. And so do some parts of the eye. Without it, one can develop scurvy, and in its most severe form can be fatal. And since it's water soluble, it's cleared through a urine, so you can't really overdose on vitamin C. But you could take a lot of it unnecessarily because you ingested a lot of vitamins that are basically passing through your body, and we don't store it. So we don't store it very long, at least. So the next 2 vitamins, vitamin E and vitamin A, are important, but because they're fat soluble, one can have too much of those, and they can become toxic. So you have to be a little bit more careful with those. The sources of vitamin E comes from wheat germ oils, palm oils, of course, green leafy vegetables, avocados and kiwis and such. Its function in the eyes and the body is to reduce the stress that comes from normal cell metabolism. When we digest fats, the cell has to react with it, make it so that's compatible with the body. And in doing so, it reacts with oxygen, and the vitamin E is able to take that reaction and convert it back so that it doesn't become a metabolic stress for the body. And in doing so in the eyes, it's able to allow the RPE cells to not break down, to not be lost over time and in the normal aging process. One other thing, if vitamin E is, it inhibits platelets, meaning it's an anticoagulant. It tends to promote bleeding. So taking high doses of vitamin E can put one at increased risk for bleeding. It's deficient in vitamin E can lead to declines in the immune system, and also atherosclerosis, or basically what happens in our blood vessels with age and with the accumulation of fat. So outside the eyes, vitamin E is also very important. We talked about the toxicity, and mostly in this promotion of promoting bleeding. And then the last of the three is vitamin A. We hear a lot about carrots because our parents told us to eat our carrots to protect our eyes. We don't really need to do that. Most of us get enough vitamin A in our diets. In fact, vitamin A can be toxic if we take too much of it. We get vitamin A from plenty of sources. Vegetables, fruits, of course, but also in the livers of most animals. That's where vitamin A is stored. In the eye, and I'll spend a little bit more time on this one, because in the eye, vitamin A is very important. There is some truth that eating our carrots help because it gives us the vitamin that is most intimately involved in the visual pathway, in the recycling of the light receptors. After they've reacted with light, vitamin A allows them to be regenerated and recycled and reused again. Without it, we will lose vision and we will go blind. So part of the reason why zinc was in the original study is because without zinc, it reduces the absorption of vitamin A. So one could take too high a dose of vitamin A. That can cause headaches and vomiting, increased pressures in our brains, suppressing bone formation. And for those who are smokers, part of the first vitamin study suggested that there may be a risk for smokers who are taking high doses of vitamin A and causing lung cancer. So since then, the other formulations of that study have reduced or eliminated vitamin A for those who are smokers. A little picture of a polar bear. One should never eat polar bears anyway, but if one eats a single liver of a polar bear, it is a toxic dose of vitamin A. So going on, the results, the new study that are to be conducted, that are ongoing right now, and its results are expected later on this year, are looking at several other supplements in addition to what has been studied already. So we know that we have looked at vitamin A, vitamin C, and vitamin E, along with 2 trace elements, and has reduced the progression to very severe macular degeneration by about 25%. Not a great success, but it helped. But remember, in the eye, there's that darker pigment, and with taking supplements that promote the generation of that pigment help. And that is the main focus of this next study, because lutein and zeaxanthin are the two pigments that are in the macula. Those are the 2 pigments that are mainly responsible for the darker appearance of our macula. There are 2 other omega-3 fatty acids that are being studied, and the omega-3s have been suggested to reduce inflammation in our body. It's been suggested to help in heart disease and other sorts of conditions that are related to inflammation. And whether or not it may be helpful in the eye as well is being studied in this new vitamins. We're looking at reducing the zinc and whether or not taking high dose of vitamin A actually helps. So those results are not yet available. I'm going to talk about the supplements, but not necessarily about its effectiveness because we really don't know yet. The lutein is one of the two pigments that are in the macula, and it acts as an antioxidant. And basically, what it does, these are also pigments that are involved that are produced in plants, and in both animals and plants, it's very much involved in protecting our eyes, or in case of plants, protecting them from light or high light levels, where when we are going through the reactions, the chemical reactions with light, the stress on the cells are reduced by the presence of these pigments. You can find them in egg yolks and turnips and spinach and kiwi, a lot of the same fruits and vegetables that you find most the original the vitamins A and B and A and C and E are also available or a valuable source of these other pigments. Zeaxanthin in particular is the more prominent pigment in our macula. It does about the same things as lutein. And again, looking at these two, we're trying to see if they're protective of our eyes also. The fatty 3 acids, we won't go into them too much. You found them in fish oil. You may have heard your doctors tell you to take fish oil. The fish don't make them. They ingest it from algae. But we can get it from eating fish or having taking in supplements of fish oil. It has been shown or suggested to show some reductions in inflammation by taking omega-3 fatty acids. It has some adverse effects in causing increased bleeding in the body, and poor control for diabetics, making them a little bit, making control of their sugar levels a little bit more difficult. So that's basically dry macular degeneration. Is there any questions about that? Yes, sir.
How much?
There's a mic up here. Do you want to?
Excuse me?
There's microphones up here. Do you want to use those?
Okay. How much does blood pressure play into wet macula?
The question is, how much does high blood pressure play into wet macular degeneration? Not that much, because in high blood pressure, and we see high blood pressure problems in the eyes all the time, but in high blood pressure, it causes damage to the blood vessels on the surface of the eye, and these are the ones that are visible here. So high blood pressure definitely causes problems for these blood vessels. In macular degeneration, the blood vessels that are most involved are the ones outside the eye, outside the retina. So it's not the ones on the surface where high blood pressure is most prominent, but the ones on the outside. And so I don't think very much at all. Okay. Yes, ma'am.
When you talk about the extrusion,
Yeah.
if a person has determined to have dry macular degeneration, they have that extrusion.
Frozen. Yeah.
Would you proceed with cataract surgery at that point?
The question is, if one has dry macular degeneration and have the presence of those yellow bodies, the drusen, should one consider cataract surgery? It depends on the severity. I don't think having drusen should prevent you from having cataract surgery, but if they're very large, if they're in the macula, it may be a reason to look at you very closely after the surgery. But just having drusen should not prevent you from having cataract surgery. And the thing with cataract surgery, it's very successful. It's done very successful in this country. But the longer we wait, the denser the cataract and the higher the risk of complications. So one ought not to wait too long either. So if you had waited a long time to have your cataract surgery, then along the way, the dry macular degeneration is actually also getting worse. And that actually puts you at a higher risk to convert to the wet kind when you have cataract surgery later. Does that make sense?
carrying on, with me personally, I was diagnosed with distributed dry macular degeneration. I had cataracts in both eyes. They were mild cataracts. I had to remove the option when I was in the site. They said, well, we'll do the cataract surgery. We should have to check. After the cataract surgery, I did have the swelling. We did the eye drops. Eventually, I ended up doing, I'm to the point where I get drops in my eye now. And I have dry macular in one eye and wet in another eye. Now, is that common as well?
I can't say specific to your condition. The question is, whether having done the cataract surgery caused the wet macular degeneration. And when we make a determination to send you to a cataract surgeon, or when your cataract surgeons look at you in the presence of dry macular degeneration, we have to make a determination if the cataracts are advanced enough to have caused the kind of vision loss that you're complaining about, or that we see when you read the eye charts. And so if your vision loss is not what we expect from just your cataract, then maybe we can say perhaps the macular degeneration is having some influence or a factor in your vision, in the decline in your vision. So without looking to see what it was before, there's no way of knowing. We know that in some cases, a little bit of inflammation after cataract surgery is normal, and in some people having that inflammation can cause some swelling inside the eye, and that may or may not be due to macular degeneration at all. So it gets kind of complicated, and unfortunately you've had sort of perhaps a conversion to the wet after your cataract surgery, but it probably was not predictable before your surgery. There are two other questions. Yes, ma'am.
I have a question. In the eyes, we have a small veins with nutrition, and as we age, microcirculation is very non-effective because there is no microcirculation. As we age, we slow down the circulation. So have you ever researched anything with microcirculation to convert nutrition more deeper into nutrition to the eye or anywhere in the eye?
The question has to do with the slowdown in microcirculation as you get older, and whether there's been research into improving the microcirculations. Not to macular degeneration specifically, but to elsewhere in the body. Part of the reason why we suggest taking baby aspirin or things that improve circulation maybe to that effect, but not to the eyes in particular. Question back there, yes, sir.
Will the NIH study throughout this year or any other studies address the situation of prevention of development of AMD in those who have a family history of AMD but do not yet show symptoms?
The question is, would the new studies of our the NIH and other eye studies suggest or any way to prevent macular degeneration for those who have a family history but do not personally show any signs of early macular degeneration? I am not aware that there are, but they may be ongoing and its results are not published, but not in the two studies that I went over just now. It's difficult to, we may at some point get into that, doing genetic testing to see if one's at risk for a whole host of diseases beyond just macular degeneration. But I think it's too early to really provide any conclusions to what kind of benefits those tests may provide at this point. Yes, sir. Yes.
Me?
Yes, you.
How effective is that shot that they give me?
I'm sorry, one more time. I'm sorry, I didn't hear your question.
From my ophthalmologist, how effective is that?
It's very effective, and I'm going to go into the wet macular degeneration in just a moment, but those shots are incredible, and they are the best thing we have so far, and I think they'll get better. There's a gentleman who has a question here. I'll get to you in just a second. He's raised his hand multiple times. Yes, sir.
Some days you see better than others. Is there a reason for that?
Yeah, I don't. There are a lot of reasons. Part of it has to do with our attention. Part of it has to do with maybe just the surface of the eye may be better, maybe less dry on one day than the others. Not particular to the macular degeneration, just particular to how we feel. So there are many questions, many possibilities to why we feel like we see better one day versus the next. Okay. One question here, this one, one back there, and then there are a couple more. Yes.
I have a question.
Yeah, I was told to take Ocuvite when I got this. Is there anything better to take now?
What's that second part?
Ocuvite. Is there something better now?
Oh, Ocuvite, the vitamins in Ocuvite are from that first study we spoke of, vitamins A, C, and E, plus the 2 nutrients, micronutrients. I don't know if there's anything better. We haven't done any studies looking at other nutrients except for the ones that are due later this year. So the only vitamins that have been studied in a large multi institutions involving thousands of patients that provided some conclusion to the benefits of vitamins is that Ocuvite formulation. And that formulation is based on that study. Okay. Yes, sir.
If you have wet macular degeneration, should you avoid aspirin altogether, or is it possible you could take a leave or ibuprofen?
So the question is, if one has wet macular degeneration, should one avoid aspirin or take a short leave from taking it? I think that's very particular to your health, and you should talk to your primary care doctor and your cardiologist and your ophthalmologist as well, because there are good treatments for wet macular degeneration. So even if aspirin causes perhaps a risk for increased bleeding, but if it's keeping your heart healthy, I don't think that should be very important as well. So it's not an easy question to answer. You have to be addressing specifically to that particular individual. I have one question back there. There's a question right over here. Okay. Yes, sir.
Thank you for sharing your information today. Are you going to be talking about the Jewel Stein Institute study on spiritual contributions that had?
I will not. And that's a very interesting topic, but with only 2 patients, it's hard to draw any conclusions. On the other hand, the stem cells were put into an eye that did not have macular degeneration. They had a separate form of hereditary degeneration, and those 2 patients have much worse vision than the patients that we talk about here. So I think that's at the frontiers of medicine. On the other hand, it's too early to apply that to a disease like macular degeneration. It was a degeneration, a dystrophy of the macula. I believe the patients had Stargardt. So that's not the same kind of progression as macular degeneration. Although one can kind of look at Stargardt as a very advanced and accelerated process of aging, but it's not quite the same. Those patients have, I believe, almost no light perception vision in that study. So which is much worse than what we are talking about in macular degeneration. I'm going to take 2 more questions. I see 2 hands, and then we'll go on. Yes, sir. Well, similar to the gentleman. Coumadin and warfarin and aspirin, as the question addressed earlier, all are anticoagulants, and so they will make you bleed a little more. You get a lot of bruising and such. And so if there's wet macular degeneration, they can cause the bleeding to continue or make it a little bit more difficult to stop the bleeding. But those medications are also very important to keeping the patient alive. So I think there's a a risk and benefit ratio that has to be adjusted for that particular individual very carefully. And I don't think any broad statements can be made about that. One more question, yes? A good place to look is the website. The question is, where would be a good place to look for trials, new clinical studies that have been done? The National Institute of Health and the National Eye Institute, their websites are a great source of information. Also, the website for the FDA for new drug approvals are a great place to start looking. So I believe it's www.nih.gov. NIH.gov. I don't know the specific. It's probably NIH.gov and NEI.gov. NEI.gov. I'm going to ask you to hold the rest. I'll be happy to answer all your questions, but I'm going to go on to wet macular degeneration, and we'll get to the rest of the questions later. Is that okay? So let's go to the wet macular degeneration. All the questions that were asked, some of those pertain to the wet kind. One can think of it as kind of a normal process to wound healing. When there is trauma to our bodies, a couple of things happen. Say you get a cut on your finger, you start to recruit these chemicals in our body we call platelets, our cells we call platelets. Those cells accumulate at the site of the injury. They act to stop the bleeding, and then you have new blood vessels that come in because you have to regenerate the tissue. And then after the tissue is regenerated, you may have a little scar that's left. And if that scar happens to be our skin, depending on where it is, it may be a little unsightly, but its function is no different. It protects us from the outside environment. So on the outside of our body, that process works great. But if you have a similar process in the eye, especially in the macula, where the architecture of those cells are so important, any scarring does great damage to our vision. So some of the two chemical signaling cells, or chemical signals that are involved, that are being made to drugs are these two, the VEGF and the PDGF. And there are a number of medications that are available, and those who are getting injections are getting one of those two variants in treating macular degeneration. So this is a photograph and OCT of a person who has wet macular degeneration. You can see a picture on your right side. That's the relatively normal right eye. You see some drusen, you see some yellow spots, but the eye is not bleeding. If you look at the OCT, there may be a little thickening down here, but the architecture of the retina looks about the same as you saw on the normal eyes. This picture obviously is abnormal, and there is something happening here. And this is a pretty typical of the wet kind of macular degeneration. It's hard to see on these pictures because they're two-dimensional pictures, but there's some swelling here. There's some more leakage out here. In fact, the leaking out here may have been a little older. And on the OCT, you'll see that there are large elevations under the retina. And that's where the blood vessels that cause damage to macular degeneration, they exist outside of the retina, where high blood pressures, those blood vessels lie along the surface or within the very superficial layers of the retina. And then also you'll see large pockets of fluids. On the OCT, those fluids appear black. So this is a picture of wet macular degeneration when the eyes start to bleed and swell around the area of the macula. And when we see that, of course, if we don't treat it, this is possibly the outcome. Now, that's not the same patient. This eye is not the consequence of what happened here, but this is what we were trying to prevent. And not too long ago, before the first medication, the first injectable medications were available, there wasn't a whole lot of treatments that are available to prevent this picture. And at this, with this big scar in the center of the eye, even though it's not bleeding anymore, the vision in this eye will be terrible. And there's nothing that can be done at this stage because there's no active disease, but yet patient has sort of gone from to a very, very poor vision, and there's just very little that can be done. So this is what we want to prevent. So what do we do? In the past, before about the year 2000 or so, we've tried many things. And the year 2000 wasn't that long ago. We've tried many things to try to arrest the bleeding in the eyes. Some of those treatments are dramatic, required surgery. Some have tried trials of radiation and or broad laser, applying lasers to the eyes. And doing that is kind of like taking a leaking sink and try to fix the leak by completely destroying your kitchen. These treatments did not work because they didn't specifically target the blood vessels that are leaking, and the damage that the treatment causes is probably worse than what macular degeneration have done or would have eventually done. So not too long ago, the goal for macular degeneration was basically to prevent patients from having very, very, very severe vision loss. And I do mean very, very, very severe. So they're not very effective at all. So since about 2004, we have the first of now many injectables. These injections are placed right into the eyes so that the central chamber of the eyes acts as a deposit chamber, a depot for these medications. And for those who are getting them, they're given about once every 4 weeks until the condition is stabilized. The first of these medications are Macugen, and then very quickly it was replaced with Lucentis. And then there's been some suggestion that Avastin, which is a drug very similar to Lucentis, is equally or almost equally effective. In 2011, Eylea was approved by the FDA. That medication works very similarly to Lucentis and Avastin. And then the most recent one, Fovista, which targets a different molecule, is not yet approved by the FDA, but has been shown to have some good benefits when it's combined with either Lucentis or another medication that targets a different molecule. So I think the point here is what we see is we're targeting the very specific molecules that are causing the problem, and not only are we targeting one, now we're using combinations so we can address multiple targets and make hopefully the recovery of vision much faster. The first thing we may do before we go on to having injections is to ask you to monitor your vision. You're too far away when we do it from there. But we ask you to monitor your vision because you're the best to tell us if there's any change. We can't bring you into the office and look at your eyes every day. But macular degeneration, when it is detected early, when the wet kind is detected early, the treatments can be much more effective than when we wait until you have had a very severe vision loss already. So one way to do so is to look at this grid. This grid is a grid that allows you to visualize whether there's any change in the architecture of the eyes. So on your left-hand side is what the grid looks like if your vision is perfectly normal. The lines should be straight. Your attention should be paid to the center black dots. It should be placed about 30 centimeters or so from you. And if you notice any change, if you notice any waviness in the lines, if you notice any blurry spots, that's a cue that something may be changing and you need to see your eye doctor right away. Okay? But it's important to do this appropriately and accurately, and to do it one eye at a time. So the grid is important and very helpful if it is done correctly. You can do the same probably if you have a magazine or a newspaper that you read. You put it at the right distance, about 30 centimeters, and cover one eye and then the other eye just for a couple of seconds. You will be able to tell if there's any words or letters missing or wavy on your book or newspaper. But we're getting a little bit away from sort of a standard diagram of grid lines to more subtle letters, and it may not be as effective, but it may be easier if it gets you to check your vision every day. It may be easier to do so if you have something that you like to read every day. So this, on the left hand, on the left side, is a diagram of all, not all, some of the little molecules that may be involved in building blood vessels and what happens when we get an injury to our body. A lot of these molecules are first identified in cancer research because cancer cells require a large supply of blood vessels. So they start to generate these chemicals to allow those tumor cells to continue to grow with their own blood supply. And the two that are most studied or that have drugs available, you'll see right there is that VEGF, and then you'll see right here the PDGF. So the names of these are not important except to say that there are many others that may be a target for therapy. So far we have one, and we may have a second one that is becoming available. So for VEGF, there has been 4 medications now that target VEGF. VEGF is it's called a vascular endothelial growth factor. Its main function is to promote growth of blood vessels, but it also causes those blood vessels to become leaky. They leak blood and they leak fluids from the blood vessels. And so in the eye, it is probably the predominant molecule that's causing or that leads to progression of wet macular degeneration. So the first medications that aim to treat wet macular degeneration is to target this molecule. And we talked about what VEGF does earlier. In the eye, when VEGF acts to promote new blood vessels, those blood vessels tend to be leaky and tend to cause a lot of bleeding. The same thing may be happening to diabetics who are getting diabetes or diabetic retinopathy in their eyes, and the same treatments are available to diabetics to treat their problems as well. There were 4 on that previous slide. I'll talk about Lucentis because it's the most promoted, and most likely you're getting injection for your macular degeneration right now. That's the medication you are using. And before Lucentis, we never had a medication that allowed patients to have a chance at getting better, actually getting more vision after their conversion. Lucentis is the first medication that's shown for that to happen. You'll see that at time 0, that's when the diagnosis or the conversion, is made. Over the next 24 months, those who are on Lucentis have on average gained about 6 letters. Most of the improvement occurs probably within the first 3 to 6 months, and then it starts to level off. Those who are not on Lucentis, not on this medication, have a severe or continual decrease in their vision as the macula starts to have more bleeding and more swelling, and eventually leads to scarring. They get from the time of onset to a much worse vision still over the next 2 years. Lucentis is injected every month or every 4 weeks, and not that continuous. It isn't that we expect more improvement in vision over time, but the drug only stays in the eye for so long, about 4 weeks or so, and it is thought that if we stop the injections, then the process continues, and then wet macular degeneration then comes back, and it'll cause decreases or vision loss again, and that's why we continue the injection. Since then, there's been other studies that looked at whether varying the time of injection or increasing the period between injections may be helpful, and the decision to do that is particular to you and how stable your disease is, so I'm not going to go into those details. More importantly, in this study, about 30% or so of those who are on Lucentis have a significant gain in vision, about 3 lines. That's 3 lines on the eye chart. So you're going from maybe 20/80 to 20/50, which is a significant gain. So, for the first time in this study, we have a drug basically that allows one to get better. It isn't going to be as good as it used to be, but it is significantly better than at the onset. EYLEA is the more recent approved medication, and in their publications, their data has matched the Lucentis data relatively well, so that the black squares are the Lucentis medication injected every 4 weeks, and the triangles and the circles are the EYLEAs given at various dosages over every 4 weeks or every 8 weeks. But the idea here is that compared to Lucentis, this medication, according to their own studies at least, works just about equally well. The Fovista, the next drug that may become available soon, targets a different molecule called the platelet-derived growth factor. And it looks to be promising that if you combine this medication with Lucentis or EYLEA, that it will be even better than using Lucentis or EYLEA alone. So until the FDA approves this medication, we're not going to talk more about it. But at some point in the future, you may have a second option to fight against macular degeneration. So a little bit about what we expect, and then there'll be plenty of time for questions. The gentleman asked earlier, what are we going to do to look at those who don't have macular degeneration but yet have a strong family history? And we have hopefully genetic testing in the future that may provide some of those answers. As of yet, we don't know. But if we look ahead, I think what we can look forward to is, one, we have more medications to fight against wet macular degeneration. We will be able to use medications that target multiple different inducers of macular degeneration, and then therefore be more effective and hopefully regain more vision after the onset. Maybe we'll be able to, with these new vitamins and supplements, significantly delay the onset of severe macular degeneration and be able to have a better diagnostic tool so that we can get to the disease sooner. And with these medications, the sooner we diagnose the wet kind, the greater the chance of getting back some very good vision. So at this point, the emphasis really should be finding those who are most at risk and monitoring them so that we can start treatment in the first sign that we see of wet macular degeneration. Yes, questions? Yes, ma'am. Okay. The question is, are we associated with a hospital? We are not, and fortunately, wet macular degeneration is not a hospital. It does not require hospitalization. The treatments are done on an outpatient office visit basis. We have a number of good retina doctors here in the valley that we can refer to, and they're located in almost every city in the valley. So the referral is easy, and if it's wet macular degeneration, because of the success of the treatment now, it's important to get to it quickly. So if we make the call to tell one of the retinal doctors that somebody has wet macular degeneration, we can get you in probably on the same day and be treated on the same day. Well, optometry or ophthalmology should be able to look at you and make the diagnosis. Now, most of the time, if it's a dry macular degeneration, we'll follow you periodically and then give you some tools to see whether the wet kind has started. And as soon as it starts, you have to come in and see us. So the more you monitor your vision at home, and we're going to help you with those tools to do that, then the easier it makes it for you and for us to make that referral and get you treated as soon as possible. So you can, if you have a doctor who's taking care of you now, follow the instructions on how to monitor your vision and what the proper sort of procedure is for you to get into the office quickly. Yes. Yes. Sir. Yes, sir.
Can you use injection in an eye with dry AMD?
I'm sorry, I heard two different questions. One more time. I'm going to get to this gentleman first, and then you. Yes, sir.
For people who are veterans, a referral from ophthalmologist to the Veterans Administration to get simply visual aids to help you as you are losing your vision from 10 years back. I know these visual aids are expensive, but for veterans or discharged from service, the Veterans Administration gives them to you.
So the comment of this gentleman was a veteran. It's a veteran. I'm sorry. The VA hospitals have a lot of tools and visual aids to help those with vision loss to cope with their condition, and they do a great job. I used to work for the VA myself in Miami, and they certainly do a good job. So if you're part of that program, I think this gentleman can give you some pointers on how to access that problem. With visual aids, and then there are plenty, and the Braille Institute does a great job. It's the access to that care that's important, and I think all of us need to be a little bit more vigilant in helping our patients seek out that access to those kinds of help and then those tools. So, but that's a great comment. One question back there from that gentleman, and then you. There was a question, the gentleman in the red, I believe.
Injections in the eye with dry AMD to stop it from progressing to the wet AMD.
Other injections for dry to stop it from wet.
What are those?
Other injections for dry that will stop it from going to wet.
Oh, the question is, are there injections or treatments for dry macular degeneration to prevent the wet kind? There is not that we know of, and that's why these vitamin studies are important at the moment, because they allow the only way for us to modify macular degeneration and its progression, possibly. Yes, ma'am. Okay. Yes.
I have a question. Can you hear me?
I can. Yes.
I've had treatment now. Is this the same thing as having a medication put in there? Or can you discuss it? Or is it two different things?
A needle in the eye? Well, you would have had an injectable medication. If it's for macular degeneration, it's likely one of the medications that we talked about. So I can't say for sure, but most likely. Yes, yes, okay. That lady right there first. Yes. Is it still turned up?
Yes.
Let me talk to you afterwards. I don't want to discuss your particular health conditions in front of everyone. Okay. One question up here, yes.
If you have the medication, one medication, and you don't see the results, is it advisable to try to change, have a different medication?
Well, the question is, if you have one medication and it doesn't seem to have helped or changed things very much, it's advisable to switch. Until very recently, there hasn't been an option to switch. The two medications, Lucentis and Avastin, work more or less the same, and Lucentis is smaller version of Avastin. So until very recently, there hasn't been an option. Possibly with the availability of IDEA, we don't know because in the studies, IDEA and Lucentis work about the same, so it's hard to tell. Yes, sir, and then the gentleman in sunglasses. Yes, sir. Yes, sir.
Are you familiar with the Allied Cell Technology study at UCLA?
The what study?
Allied Cell Technology at UCLA. They're treating dry macular right now, and they've had people with definite improvement. They hope to progress to the west. Are you familiar with that at all?
I am not. What was the name of the study one more time?
Allied Cell Technology.
Okay.
At UCLA.
Okay. I have to look into that. Yes, sir. The sunglasses. Yes.
Okay. For somebody who has drusen and nothing else at this point, is there a recommendation for dosage of lutein and I think not the other one, zeaxanthin?
So for those who have drusen, is it a good idea to take lutein and zeaxanthin? Is that the question?
Yes.
We will know for sure when the results of the AREDS-2 study come out, and that those are two pigments that they are looking into specifically. I have seen in drugstores already plenty of supplements that advertise lutein and zeaxanthin along with the AREDS formulation. I can't say for sure, but it looks like obviously some people think it's promising. Some drug companies think it's very promising. Yes, yes, ma'am. The question is when we talk about medications for dry macular degeneration, it is not an eye drop. These are vitamins that you take, just like a multivitamin. So these are supplements that you take by mouth. Okay. Pertaining to eye drops, there are no eye drops for macular degeneration. There are plenty of eye drops for other diseases and other conditions, but not for dry macular degeneration. I hear dry eyes, and I think that's absolutely correct. You may have dry eyes, which require some eye drops. There's another question right back. Yes, ma'am.
Is there anything that could be done for a rift in the pigment cell?
I didn't catch the last part.
Is there anything that could be done for a rift in the pigment cells?
Is there anything that can be done for a rift in the pigment cells? Not really. Unfortunately, no. Yes. I'm going to get to this question and back to you. Yes, go ahead. The question is, have I heard of Aculen? I have not. I apologize. I'll look into it. Yes, ma'am.
I was just going to comment on that ancillary grid.
Yes.
My doctor told me that it is very important to check that grid every other day at least. You do have to use wet macular
Yes. So the comment is this lady was advised to look at the ancillary grid at least every other day. And I would say every day would be a good advice. And it is a very sensitive tool because of the way the grids are lined up. It is a very sensitive tool to detect any change in your vision, especially in the macula. So if you have a grid at home, looking, it doesn't take very long. It takes 5 seconds or so in each eye, but looking at that grid every day will detect early changes to any swelling or bleeding in the eye, and with the importance of early diagnosis, any changes on that grid should be notified to your doctor and checked out immediately. Thank you for comments. Yes, ma'am.
Are there, like, is it impacted at all by reading on smartphones, reading on book technology devices? Is there any impact on getting macular degeneration?
I hear that question a lot. Is there any damage or any potential damage from using, reading a lot, looking at smartphones and tablets and such? No. Reading does no harm to the eyes. Sometimes it causes some fatigue and dry eyes and things of that sort, but it would have no damage and would not cause any damage. There's another question right up here, actually. Yes, sir. Well, the question is if your doctor does not see any indication for dry macular degeneration, should one request a photograph? Photographs are great. They are the best way to see how things are going right now and then compare for future reference. But photographs are also expensive, and so I think one has to weigh a little bit on the medical necessity of testing and why it needs to be done. If your eyes are really perfectly healthy, there may not be a reason for a photograph, just purely on the cost of effectiveness of that procedure. That's the only thing I would have to say about that. Yes, sir. Question is taking all the medications for dry eyes, not dry macular degeneration. Taking all the vitamins for dry macular degeneration? Well, the hope is that, no, it will not counteract your injections, but the hope is that it will prevent the eye that hasn't had the wet macular degeneration from converting. That's the hope. Yeah. Yes, ma'am?
I have hereditary MD, and I've just been diagnosed about 5 years ago. My doctor only wants to see me once a year. Is that all right?
So the question is hereditary macular degeneration. The doctor only wants to follow once a year. If you feel comfortable with your doctor and he or she only wants to see you once a year, I think that's great news. That means they're not all that concerned about your condition. There's a very low probability that something really bad's going to happen to you.
So, this is kind of a catchy question. I don't know if I feel comfortable with my doctor or not, because it's not like it's something that's, if you're still hurting after 10 months and you see another doctor, with my eyes,
That's a very valid point. I completely understand the question. The comment is, how do we know? When it comes to a joint pain or something like that, or even cataracts, we can feel when things are not right, when things are not getting better. But when it comes to a condition where we don't notice any change until it gets really bad, what should one do? It's a tricky question. I think we should all do a little research on our doctors and see what their backgrounds are. If your doctor has a very a specific background in retina and has had extensive training in the retina, then I think his or her advice would be very valid. It would never hurt to get a second opinion, even maybe just one time, to see if another doctor feels the same way, without at all trying to suggest that you should leave your doctor. But a second opinion on occasion wouldn't hurt. It's definitely a touchy question. No problem. Okay. Yes.
The sun is right against your eye. These little ones that you have, fluorescent lights, how much damage can that cause?
Even though those lights appear bright, they are nothing compared to the sun. The intensity of sunlight is way beyond what those lights are able to produce. So, and it's somewhat controversial whether the sunlight causes macular degeneration. Not that sunlight does no harm. We know UV radiation does a lot of harm, but there are other parts of our eyes that block essentially all the UV radiation getting into the interior of the eye.
But it's the way I can see, she doesn't understand.
If it's a bright handheld light, that's not going to do any damage. Yeah, bright lights are sometimes the only refuge to having some vision. The lights provide the contrast to allow one to see a little better. Yeah, and it's not the same as the sunlight. One should never stare at the sun or stare into the light, but having the light overhead certainly can be helpful. Yes, ma'am. The question is, could a cataract hide the fact that you have macular degeneration? Absolutely. Depending on the density of your cataract, and some can be so dense that we cannot see into the eye because of the presence of the cataract. And in that case, it's impossible to know what's going on inside. Now, the prudent thing to do is to do an ultrasound to be sure that the interior of the eye looks normal. But the ultrasound is not very sensitive, and so if there's a little bit of bleeding from macular degeneration, there's no way the ultrasound can tell. And often, in those cases, it isn't until we take out the cataract that we can see the macular degeneration. So that's certainly a possibility, yes. Oh. Any other questions? Yes, sir. Shao. That's correct.
That was very informative. Thank you.
You're very welcome. And thank you for coming. My pleasure. I'll stick around if you have any questions afterwards as well.